I'd love to talk a little bit about hormone replacement therapy in men. When one looks on social media and the internet, there seems to be a younger and younger cohort of guys, people in their teens and 20s, showing up to the table thinking that injecting testosterone cypionate or taking Anavar or whatever it is going to be the right idea. They mainly seem to be focused on cosmetic effects. I'm not a physician, so I can't say whether or not they were actually hypogonadal, et cetera. But it seems to me, again, correct me if I'm wrong, but it seems to me that similar to the Attia's rule as it relates to longevity, that we could come up with a broad contour rule in which if a male of any age is not trying to get decent sleep, exercise appropriately, appropriate nutrition, minding their social connections, et cetera, the idea of going straight to testosterone seems like a bad idea. That said, just like with depression and antidepressants, there is a kind of a cliff after which low enough testosterone or low enough serotonin prevents people from sleeping, exercise, social connection, et cetera. So I do want to acknowledge that. But with that in mind, how do you think about and perhaps occasionally prescribe and direct your patients in terms of hormone replacement therapy in men? Person in their 30s, person in their 40s, who's doing almost all the other things correctly. What sorts of levels do you think are meaningful? Because the range is tremendous in terms of blood tests, 300 nanograms per deciliter, I think on the low end now in the US, all the way up to 900 or 1200. That's an enormous range. What are some of the other hormones you like to look at? Estrogen, DHT, and so on.
So a lot to unpack there. So let's start with the ranges, right? So the ranges you gave are for total testosterone, of course. And we don't spend a lot of time looking at that. I used to spend more time looking at total and free when I used more tricks to modulate it. So I'm actually far more simple in my manipulation of testosterone today than I was 6 or 7 years ago. 6 or 7 years ago, I mean, we would use a microdose of Anavar to lower SHBG in a person who had normal testosterone but low free testosterone.
What was a low dose of Anavar in that context?
10 milligrams subling 2 to 3 times a week.
Anavar basically being DHT, oxandrolone.
Yeah, exactly.
And again, we're not recommending this. This actually, if you're playing a competitive sport, can get you banned from that sport. It can also get you banned from having children if you do it incorrectly.
Yeah. So a microdose of this has to be small enough that it doesn't impair your body's ability to make testosterone. But Anavar has such a high affinity for SHBG that it basically distracts your SHBG from binding your testosterone.
Freeing up testosterone.
That's exactly right. So the goal was, how do I just give you more free testosterone? So if a patient shows up and they've got a total testosterone of 900 nanograms per deciliter, which would place them at, depending on the scale you look at, the scale we look at, that would place you at about the 70th percentile. But your free testosterone is, 8 nanograms per deciliter. So that's pretty bad. That means you're less than 1% free. A guy should be about 2% free T. So that dude should be closer to 16 to 18 nanograms per deciliter. So in that situation that I just gave you, his SHBG is really high. His SHBG is probably in the 80 to 90 range.
That's very high.
Yeah.
Because I think the upper range is somewhere around 55, 56.
Exactly.
Yeah.
So we would first backstall for what's driving his SHBG. So there's basically 3 hormones. So genetics plays a huge role in this. There's no question that just out of the box, people have a different set point for SHBG. Mine is incredibly low. My SHBG is kind of in the 30s, 20s to 30s. But from a hormone perspective, there's basically 3 hormones that run it. So estradiol being probably the most important, insulin, and thyroxine. So we're going to look at all of those and decide if any of those are playing a role. So insulin suppresses it. So this is actually the great irony of helping a person get metabolically healthy, is in the short run, you can actually lower their free testosterone, all things equal. Because as insulin comes down, SHBG goes up. And if testosterone hasn't gone up with it, you're lowering free testosterone. So then the same as with estradiol, so except in the opposite direction. So higher estradiol is higher SHBG. So again, occasionally you'll see a guy with normal testosterone, but he's a very high aromatase activity person. So he has a lot of the enzyme that converts testosterone into estradiol. You can lower estradiol a bit with an aromatase inhibitor. and that can bring down SHBG. Now, again, these things individually are rarely enough to move the needle. The last is thyroxine. So if you have a person whose thyroid is out of whack, you have to fix that before if their T4 is out of whack, you're going to interfere with SHBG.
Do you still use anabolics, oxandrolone, to try and lower SHBG?
I don't.
Because it's too potent?
No, because it's just too complicated for patients. It's a drug that can't be taken orally, so you have to take it under the tongue,
like
right?
a Troche or something,
right?
Yeah.
But then I had one patient once who, even though we told him about 87 times that, he was like swallowing the anavars and his liver function, and he was like, we're talking 10 milligrams 3 times a week is a tiny dose, and 3 months of him, or whatever, 2 months of him swallowing that every time tripled his liver function test. So I was like, it's just not worth the hassle of doing this. For perfection. In reality, we can fix this another way. So the first order question is, do we believe clinically you will benefit from normalizing your free testosterone or taking it to a level that's, call it 80th to 90th percentile? So upper normal limit of physiologic ranges. That's the first order question. And that's going to come down to symptoms, and that's going to come down to some biomarkers. I think there's 2 years ago, was it 2 years ago or maybe a year ago, very good study came out that looked at pre-diabetic men. You've probably talked about this study, and looking at insulin resistance and glucose disposal with and without testosterone. And the evidence was overwhelmingly clear. Testosterone improves glycemic control. Testosterone improves insulin signaling. This shouldn't be surprising, by the way, given the role muscles play as a glucose reservoir and a glucose sink. So now I include that as one of the things that we will consider as a factor for using testosterone. Now, again, it's not the only one. So you can accomplish that with exercise, you can accomplish that with these other things, but then you get into a little bit of the vicious cycle of, will having a normalized testosterone facilitate you doing those things better? So let's just assume we come to the decision that this person is a good candidate for testosterone replacement therapy. The next question is, what's the method we're going to do it? Are we going to do it indirectly or directly? So clomiphene is a fertility drug. It's a synthetic hormone. It's actually 2 drugs, M-clomiphene and I forget the other one. And it tells the pituitary to secrete FSH and LH. So so the advantage of Clomid is it's oral, and it's meant to be taken orally. So, a typical starting dose would be like 50 milligrams 3 times a week. And if you do that, you'll notice in most men, especially young men, FSH, LH goes up. In any man, the FSH and LH go up. But if a man still has testicular reserve, he'll make lots of testosterone in response to that. Because that's the first order question we're trying to answer is your failure to make testosterone central or peripheral?
Yeah. And I think just want to point out, again, correct me if I'm wrong, but my understanding is that a lot of the drugs that we're talking about, the synthetic compounds, testosterone, estrogen, things related to growth hormone, et cetera, were discovered and designed in order to isolate and treat exactly these kinds of syndromes, whether or not it was the hypothalamus, the pituitary, or the target tissue, the ovaries or the testes, correct?
Correct. Yeah. I mean, I think the easiest way to go about doing this is just give the hormone that's missing without attention to where the deficiency is. Mm-hmm. Why this becomes relevant is if you have a 35-year-old guy whose testosterone is low, but you can demonstrate that it's low because he's not getting enough of a signal from the pituitary, why would you bother giving him more testosterone when he has the he has the Leydig cells and the Sertoli cells to make testosterone? He just needs the signal. Mm-hmm. Sometimes, though not always, just a course of Clomid can wake him up, and he's back to making normal testosterone.